Hello, my name is Cooper Dodd. I'm a PGY2 at St. Joseph's Baycare IM residency program. I am here presenting a case titled Double Trouble, a rare case of dysphagia in a young adult. So for the introduction, dysphagia is a common complaint. It has a broad differential. This ranges from structural and motility disorders all the way to extrinsic compressive causes. Among these, vascular anomalies are a relatively rare cause in adults, and they're often overlooked due mainly to their absence of respiratory symptoms on presentation. So one of these anomalies is a double aortic arch. It accounts for about 1 to 3% of congenital cardiovascular malformations. Adult presentations are exceedingly uncommon, and they usually manifest with progressive dysphagia, such as our patient here. So in this case, we present a 28-year-old male. He has a history of a hiatal hernia. He presented with progressive dysphagia to solids and thick liquids over several weeks. His symptoms advanced to the point where he was dependent on a blended diet, and then this eventually just escalated to low viscosity liquids. He came in and obtained a barium swallow, and this revealed extrinsic compression of the upper thoracic esophagus, and that produced this characteristic waste at the level of the aortic arch. So, given that almost pathognomonic imaging finding, a CT angiography was ordered, and it confirmed a double aortic arch encircling and compressing the esophagus, and this is what formed this vascular ring. Incidentally, there was this partially calcified mediastinal lymph node, and there was a lymphoproliferative disorder being suspected, and the main one that came to mind was Castleman disease. He did progress to endoscopies for his workup after the CT, and that also demonstrated this extrinsic pulsatile compression, and was about 25 centimeters from the incisors. He was ballooned during the endoscopy in an attempt to provide symptomatic relief. However, this was not successful. So, for this reason, surgical intervention was recommended. So, he underwent a left posterior lateral thoracotomy. There was ligation and division of the non-dominant left aortic arch, and there was intraoperative cryoablation performed at T3 through T7, and this was mostly for pain control. Recovery was overall uneventful. He was discharged post-op day 3, and he was also given follow-up for ongoing outpatient evaluation for this mediastinal mass or lymphoproliferative nidus that was being looked into. So, overall, the case it's an unusual case of dysphagia in the adult, and the main sort of emphasis here is that he had an atypical presentation, and that's mostly in the sense that it was not caught in childhood because there's a lack of respiratory symptoms, and his only manifestation really in his adult life was this progressive dysphagia. So something to keep in mind, that even though the vascular anomalies are relatively rare, they should, be considered and chased when the imaging is suggesting any extrinsic esophageal compression. Early recognition and prompt surgical management gave this patient, his quality of life back to the point prior to presentation. Thank you.